Now we will move on to the image evaluation portion of the BE trigger. Before any barium enema, you want to take a just standard AP or PA KUB before tipping the patient and putting the contrast into their body. You would just want to make sure that all fecal matter has been voided from their system, because any excess fecal matter that is in the system could appear to be a polyp and give a false positive. So we want to make sure their entire system is clear, and just like a normal KUB, you know, we want to go and see the posterior margin of the diaphragm, and we want to go down to the pubic symphysis. And for Kiki, since she's tiny, I would have done the scout at 80 kVp at 25 Mass. So then once you have your patient tipped and your radiologist in the room and the barium has been inserted, the first image taken will be the AP right lateral decubitus. For this position, the patient will be lying in a true lateral position on their right side. The X-ray tube will be in front of them, so it's an AP. The central ray will be horizontal and perpendicular to the IR, which is centered at the patient's midline, so you can see that by the spine. And the IR will be centered at the level of their iliac crests. So in the decubitus positions, you're looking, well, actually for any of these images for a barium enema, you're looking at the air-filled portions of the colon. So in the right lateral decubitus, the barium will be on the lateral side of the ascending colon, which is here, and the medial side of the descending colon, which is here. So we are looking at the air-filled portions, which is the medial side of your ascending colon, and you're also looking at the lateral side of your descending colon. The next image in this series will be the PA oblique in the right anterior oblique position. So for this one, we see by looking at the lumbar spine here, you can see the Scotty dogs are facing our anatomical left, which is that way. So for this one, we're seeing the right colic flexure is going to be open, so there's not going to be any superimposition here in the flexure. And then we're also going to see the ascending colon and the sigmoid colon open and free from imposition. As you can see here, the left colic flexure is kind of turned in over itself, so that side is not visible, whereas our right side is visible. And as you can see, the left side, left colic flexure, is much higher than the right colic flexure, and that's because the liver's over here pushing down. And for this one, the CR is going to be perpendicular to the IR. We're going to be about 1 to 2 inches lateral to the midline of the body on the elevated side. Since this is RAO, that's going to be your left side, and it's going to be level at the iliac crests. Now we'll move on to the PA projection. In the PA projection, you want to make sure that you can see both colic flexures, the right and the left, in the image, and you want to be able to see the entire bowel, including the ascending, transverse, descending sigmoid. For this one, your CR is going to be perpendicular to the IR. The midline of the IR is going to be lined up with the midline of the body as seen by the spine, and it's going to be centered at the level of the iliac crests. In the PA position, the patient will be lying prone. So the structures that we'll be viewing are the ascending and the descending colon, because those are posterior structures. So those will be filled with air, whereas the transverse and the sigmoid colon will be filled with barium, since those are more anterior structures. Sometimes placing the patient in a slight Trendelenburg position will help if there's a lot of overlapping of the bowels. The bowels can superimpose on each other when they twist over, so placing the patient in a slight Trendelenburg angle can kind of help elongate the bowels so we can see everything, since we kind of want to see everything in the PA position. The pathology seen in this PA projection is diverticulitis of the colon. So diverticula are small bulging pouches that form in the lining of the colon, and diverticulitis doesn't necessarily have to be hazardous or painful to the patient, but if it gets inflamed or infected, they can get impacted, which will cause infection or inflammation. When they become impacted or inflamed, that can cause pain and pathology to the patient. Our next projection is the AP axial projection. For this, the central ray is going to be angled 30 to 40 degrees caudad. We're still centered at the midline as seen by the vertebral column, and we're still centered at the level of the iliac crest. So the axial position or projection is going to show the rectal sigmoidal area free from superposition. So in this projection, we can cone down a little bit just to the sigmoid, colon, and the rectum. We do not have to see the entire bowel, so we don't have to see the right and left colic flexures. As you can see, we're collimated in close here. But the axial angle is going to show us the sigmoid, which is up here, and the rectum that's down here, free from superimposition. Whereas usually just in a normal PA, it's going to be folded up on itself. Now we're viewing the PA oblique, left anterior oblique position. We can see that we're in an LAO because our Scotty dogs, which are ear, face, are facing to our anatomical right. So our CR is going to be perpendicular IR. It's 1 to 2 inches lateral to the midline of the body on the elevated side. So since this is an LAO, it's 2 inches lateral on the right side of the body. And again, we are at the level of the iliac crests. The patient's going to be turned 35 to 40 degrees obliqued. And for this projection, we're going to see the left colic flexure open, which is here. As you can see over here on the right, there's a lot of superimposition and a lot of folding in of the bowels over here. So here, the splenic flexure is open, and we can see the descending colon free from superimposition. So we're looking at left colic flexure, descending colon, and over here, which is the ascending colon, you can see that it is folded up and superimposed on itself. Now I'll be looking at the PA left lateral decubitus position. For this, the patient will be lying in a true lateral on their left side. The central ray is going to be horizontal to the patient and perpendicular to the IR, which is centered at the midline of the body, as you can see from the spine, and it is centered at the level of the iliac crests. We are again looking for the air-filled structures. So for the left lateral decubitus, the bowels that are filled with air will be the medial side of the descending colon, which is here. And as you can see, the lateral side is filled with barium. And then this is our ascending colon, so the lateral side of our ascending colon is filled with air, whereas our medial side of the ascending colon is filled with contrast. In this image, all these little kind of circle dots, those are polyps. Polyps are just small masses of cells that form usually in the lower part of the colon, and they can be non-neoplasmic or they could be neoplastic. So non-neoplastic is not cancerous, but they could be a precursor to cancer, or they could become cancerous. So, yeah, obviously you cannot see any polyps when there's contrast in the bowel. So that's why we want to do a double contrast study to look for polyps, because you can only really see them in the air-filled structures. Here's the left lateral rectum image. As you can see, here's the rectum, and here's a sigmoid colon up here. But this is basically showing the rectum free from superimposition of the sigmoid, because a lot of times it gets bunched together and is superimposed. So we can cone down a lot on this image. The central ray is going to be perpendicular to the IR at the mid-coronal plane and at the level of the as-is. But since we're really only focusing on the rectum, we do not need to see the entire colon, so we don't need to see both flexures. We're just collimating in down to our colon, our rectum, and we want to see a little bit of the sigmoid colon here. Once all the necessary images have been taken for the BE series, we will deflate the balloon, take the enema out of the patient's rectum, and we will let them use the restroom. They will come back, and we will take one post-evac image that will can just be AP or PA. We'll shoot it like a normal KUB. And that's